Very good morning, ladies and gentlemen. Thank you so much for joining us this morning. It's a lovely Saturday morning where I am, and I hope it's the weather similar for the rest of y'all. We're coming up on Chinese New Year, so happy Chinese New Year really in advance for everyone who's joining us. This installment today is this year 2022's first installment of the SK Dharmalingam lecture series, and we're very proud, honored to be able to partner this year to carry out this series via Dokity. So my name is Murallitharan, and I'm with the National Cancer Society of Malaysia. And this morning we're speaking to you about cervical cancer in conjunction with Cervical Cancer Awareness Month in January. And the SK Dharmalingam lecture series is a series designed to provide insights on different cancers, different aspects of cancer management, especially to primary care, as well as those of us who are in hospital practice. So this morning, we're very privileged and honored to have with us Dr. Arivendran Dhorai. Good morning, Doc. How are you? Very sorry, Doc, you muted a little bit.
Yeah.
Okay.
Hi,
good morning, Doc. How are you?
Good. I'm good. Thank you so much.
Okay. Thank you so much for joining us and taking time off your busy day and joining us this morning. Ladies and gentlemen, Dr. Arivendran is a consultant gynaecological oncologist with Pantai Hospital Keroh, which is in Malacca, southern state in Malaysia. Without further ado, please allow me to introduce Dr. Arvind's session. He will speak to us today about this incredibly interesting topic on no touch can see. I'll leave it to Dr. Arvind to kind of figure out where this is, but actually more or less what we are kind of wanting to highlight is the fact that cervical cancer detection has moved far beyond, the times of invasive kind of procedures, especially pap smears. Now, pap smears remain a very effective mechanism for screening, and they're cheap and very easily done with minimal training. However, as we have seen, they're not too popular. People don't really like to do them. Increasingly, women are very concerned about the invasiveness of the procedure. And so newer tests, newer, mechanisms have been invented. They've been deployed. We've seen some of them, and Dr. Arvind will speak a little bit about that as well this morning. And I hope you all will be able to get quite a lot of insights from the session. And of course, please feel free to drop any kind of questions that you have, except for Dr. Arvind's personal number. No, I'm kidding. If you have a patient to refer, I'm very sure Dr. Arvind will be very happy to kind of accommodate you as well. Let's listen to the session. We're breaking into two parts. One speaking about cervical cancer as a whole, and then we're going to speak specifically about cervical cancer and management in Malaysia. So without further ado, please allow me to turn the screen over to Dr. Arvind. Doctor, it's all yours.
Thank you, Dr. Murali. Thank you for the lovely introduction. I will start by sharing my screen. Yeah. Is it right? See? Yep.
Yes.
Very good morning, everyone. Good morning, Dr. Murali. Thank you for having me on this series. It's an honor. My name is Arvind. I'm a consultant gynae-oncologist in Pantai Hospital, Malacca, and also in Malacca General Hospital. So today I'll be talking about cervical cancer. Since it's January, it's Cervical Cancer Awareness Month. And I think the basic concept that the main highlight I want to highlight is that early detection saves lives, right? So it's not the major surgeries that I do, the radical surgeries that I do that actually saves lives, but it's actually more the screening and the early detection, that the primary care that you guys do that actually saves these lives. So that's what we're going to highlight during this lecture series. So I'll start off by first saying a very heartfelt big thank you to the National Cancer Society of Malaysia. I think I've been working with you all since 2017, since I got back to Malacca, and heartfelt thanks to Dr. Murali, Mickey, Madam Vijay, and the team in Malacca here who has been have given us abundant support and guidance over the past years. Even when I went to Sabah, they came with me to Sabah and helped my patients. They couldn't be there in person sometimes, so as you can see some of the pictures, they will video call and counsel and direct my patients. So I'm truly indebted. All I say, keep up the good work, and we hope to continue working for many, many more years. So as we all know, January is Cervical Cancer Awareness Month, all right? And basically, cervical cancer affects about 500,000 more women worldwide. And unfortunately, more than half of them will die from the disease, all right? So we were never winning until the past 10 years maybe. And suddenly we had the HPV vaccination, and the vaccine currently, which can protect against 9 types of HPV, was found to be effective and thus preventing cervical cancers. So cervical cancers right now is a disease that can be prevented and also can be treated if it's detected early. So from a disease that was killing more than 250,000 women per year, now we've got a disease that we could actually eradicate as long as we have a good screening program, a good screening test, plus a good vaccination program. So it can be effectively treated and prevented with those modalities. So the outline of my lecture today, I'll be just talking about cervical cancer as an overview. You're going to understand about the human papilloma virus, which is the culprit of almost 95 to 97% of all cervical cancers and how it plays its role. We're going to talk about primary prevention, which is basically the HPV vaccine. We're going to talk about secondary prevention, which is basically the screening tests that we have, like the pap smear, the HPV DNA tests, visual inspection acetic acid. And right now, which I'm really excited about, is the self-sampling HPV DNA, where women can actually do the test by themselves at home and send it to the lab and get it tested. So that's very exciting. And finally, just a little bit on the Malaysian perspective and the challenges in eliminating cervical cancer, because I believe that we have a really good chance to follow countries like Australia, who have almost eradicated cervical cancer. And with accordance to WHO's goal that we're trying to eradicate or eliminate cervical cancer by 2030. So as you know, worldwide, 600,000 women will get cervical cancer and 340,000 will die from it. Unfortunately, the main bulk of these cases of cervical cancer are from the low and middle income countries like Africa, Sub-Saharan, right, where they have poor support, they do not have a good screening program, HPV vaccine is hard to come by. So it would be difficult to reach that WHO goal of 2030 if these countries are not being focused on. Countries which are very developed, like Australia, has almost eradicated it. England is following suit, Sweden, all right? So they're doing well, but it's the low and middle income countries that we need to work on. Malaysia is on the right path because we have got a very good HPV school-based vaccination program, which is doing an amazing job. Right now, we just need to find the right tools of screening. Our pap smear screening program has not really done really well since it's been introduced in 1995. But right now, with the introduction of HPV DNA testing in the primary setting, plus hopefully soon they'll bring in the self-sampling for women, we could increase the uptake of screening from a measly 40 to 45% to maybe hopefully a 70 to 80%. As you can see, the countries that are basically affected are mostly the less developed countries, and the main burden of this HPV infection and cervical cancers are in this region. All right, and Asia is part of the middle income countries compared to America and Australia and so forth. Risk factors for HPV, I think we all know this, early onset, multiple sexual partners, but as I said, anybody from my experience working as a gynaecologist, we have seen cervical cancers in women who had one sexual partner, or cervical cancer in women who never had sex, or with other comorbids. So basically, to me, anybody is at risk. Any female is at risk of cervical cancers, because even though most of them, 98% of them are due to HPV, there's a small percentage that are non-HPV related that needs to be screened to, right? But the ones that are on screen, the cigarette smoking, immunosuppression, STIs, those are the ones which will increase your risk of. getting cervical cancer. So I've said this is the questions that I would be asking at the start of the lecture. Can cervical cancer be eradicated? Australia has shown that it can be, with 2 good strategies, a good screening program and a good vaccination program. Can it be prevented? We know it can with the vaccine, and it's shown to be very efficacious. So cervical cancer is a completely preventable disease, all right? As long, most of us will get HPV in our lifetime, 80% of us will get the infection, but most of us will clear the infection. It's the ones where it's persistently HPV in the cervix that leads to precancerous changes that eventually leads to cervical cancer. All right, so that's the key there, persistent infection with high risk HPV. All right, so those are the group of people that we need to focus our screening and our treatment on, not the ones who have transient HPV infection, not the young ones which will have infection and it will go away, but the ones with persistent high risk HPV subtypes. Second point is the HPV vaccine. You know, I think a school-based program, we have touching about 92 to 95% of almost all school girls. This is basically more in West Malaysia compared to East Malaysia. And the vaccine is shown to be efficacious. So we will not see the results immediately because we only started in 2010 and it usually takes about 20 years. And that's why hopefully by 2030, we will see a much lower incidence of cervical cancer in Malaysia. The burden of cervical cancer, as you know, it's dropped over the years, especially worldwide. As you can see, it's now number 10 compared to behind breast, colorectal, lung, prostate, liver, and that's because of the vaccination and good cervical screening programs in developed countries. In Asia, we're doing not too bad, all right? As usual, we're still above Singapore and Vietnam, surprisingly. But I guess we can do better, and because the way to do it is basically, I think we need to focus on our screening strategies and picking up those with persistent high-risk HPV infection. So what do we have? Roughly about 2,000. I usually tell people we usually have about 2,000 patients diagnosed with cervical cancers per year, and now it's dropped to 1,008 and now it's 1,007. This statistics estimates for 2020. The crude incidence rate is about 11.1. The age sterilized incidence rate is about 10.2, right? And it's much lower compared to the rest of Southeast Asia. So in Malaysia, as I said, we see about 1,800 cases, and as I said, most of them present in advance, like stage 3 to stage 4 disease, about 50 to 60%. It's only maybe a small 40% of them will be stage 1 or stage 2. However, it still ranks number 4th in the leading. It was previously number 3, now it's dropped to number 4. So I guess as long as it continues dropping, that means our vaccination program is doing well and our screening uptake is improving. However, it's still the second most common female cancer in the women in age 15 to 44 years because those are the reproductive age group where they are sexually active. Age-specific incidence rates of cervical cancer goes up with time. I always tell my patients, as long as you continue living, you will eventually get one cancer. And that holds true. I mean, I saw a lady yesterday who was about 85. She had a good life and now she's got cancer. I've seen that my mom, my friend's mother who was 93, which I operated on, and she developed cancer. So as long as you get growing older, the age-specific incidence rates of cervical cancer will go up because of our aging population. So about 1,009, 1,008 cases are diagnosed annually in Malaysia, and it's, I said, the 4th, all right? We do see them late, especially when I was working in East Malaysia in Sabah, all right? I think out of 10 cervical cancer patients, probably 7 would be in stage 3 and stage 4, maybe 3 would be in stage 1 and stage 2, which is a bit reversed in West Malaysia, probably because we have more facilities for screening. We have a better vaccination program here in West Malaysia. So probably out of 10 cervical cancer patients in West Malaysia, we probably see a 5 or 6 which are operable, and probably about 2 or 3 which are stage 3 and stage 4. So as you can see, the annual number of cervical cancer patients according to age, it really peaks at the age of 40 to about 70, all right? So this is the age that we need to target, and this is the main bulk of our patients, all right? Why? Because most patients will get HPV at the age of 30 when they get married and have sexual activity. And those group where the HPV is persistent, which I said about 10% of those people, they will start developing changes here from 30 to 40, right? These are where they get their precancerous changes due to persistent high-risk HPV infection. And when they come 40, they become cancer. And that's when, you know, the main bulk of our cancer patients are, all right? So the main group, if you want to target for screening, would be the age between 30 to 40. And that's why HPV DNA testing is encouraged for those who are above the age of 30. So the incidence of mortality, if you can see cervicals, this is in Malaysia, all right? We have 1,700. The cumulative risk is about 1.12. The 5-year prevalence is about 4,900 to all ages, all right? So if you look at the deaths, it's about 9,000, it's about 1,000. So as I said, still about more than 50% of them will die. So we're still not really winning in terms of survival. And that's the reason, because most of them present at a stage 3 or stage 4 where cure is a bit difficult. In comparison, if you compare to countries like Australia, where I think I was there for about 2 years, we only see probably a stage 3 or stage 4 1 year, and mostly we detect them when they're precancerous. So I'm going to show you this. This is what we see in developed countries like Australia, Sweden, Norway, Canada, all right, where cervical cancer or precancerous changes are detected at such an early stage, all right, even cervical cancer. And this is because they have a very good screening program and a very good vaccination program, right? So those with precancerous changes or those with persistent HPV infections will get detected and they will get treated. In Malaysia, we don't do too bad, all right? We still see them a bit later, like stage 1B1, 1B2, where the size is about 2 to 4 centimeters, 2A, 2B, we do get them. So we need to move towards precancerous because that's where the morbidity is less. When you do work times, you do radical surgery and then followed by radiotherapy, the morbidity to the patients are much more. So we need to improve our screening strategies. And this is what we want to avoid. We really want to avoid them when they are at this stage. You don't want to go in when they're bleeding, infected like this. You know, the morbidity to the patients, it's bad. All right. Patients have a lot of complications, bowel complications, urine complications. So this is what we do not want to see. But this is what's happening in certain parts of the country in Malaysia and also in low-income countries. So let's talk about the human papilloma virus. All right, the main culprit, the main virus that actually causes 98% of cervical cancers. All right. HPV, we know there are like 100 to 200 subtypes of them. All right, and they can be divided into low risk and high risk. The most commonest low risk are type 6 and 11, which we see causes basically warts, not very worrying, but can be troublesome to treat. We have high risk HPVs. We have about 14 subtypes of high risk HPVs, and we know that 16 and 18 are the most carcinogenic. So if you got 16 and 18, irregardless of your pap smear, you'll still need a colposcopy, all right? Because they carry a very high risk of having precancerous changes and cervical cancers much faster than other high-risk subtypes. So HPV 6, 11, 16, 18, 31, 39, 45, 52, and 58 are the 9 most common types, all right, in HPV-related disease. And that's where we got the vaccine of the nanovalent, all right? And you can see they cause basically almost 85 to 90% of cervical cancer, vulva, vaginal, anal, high-grade, low-grade, and genital warts. So if you do get vaccinated with the nanovalent, the 9 HPV subtypes. So you got a protection about 85 to 90% from all these diseases. Compared to previously, we had the quadrivalent, which was only giving us about a 75% protection. The HPV disease burden among females and males is a bit unequal because, I mean, the biggest carriers of HPV are males, right? You can probably figure out why, but a lot of people ask me, why don't males get penile cancer? They do get penile cancer, but most of the time it's not really HPV per se, and compared to cervical cancer, which we know that 98% of it is due to HPV. And that's the reason because of our anatomical configuration of the penis and the cervix. So even though we are the biggest carriers of HPV, but it's the females that actually harbor the virus and develop the consequences of harboring the virus for the prolonged period. So you can see penile cancer, vulva, followed by anal, followed by oropharyngeal, then only cervical, and then dysplasia, and then genital warts. So the females face the brunt of most of the HPV, persistent HPV infections. Thus, that's why another point is that we are trying to promote gender equality vaccination, where we are starting to encourage the boys to get vaccinated as well. And this will lead to a herd immunity. For the boys, it might not protect you against penile cancer or anal cancer, but it might reduce your risk. But it will definitely reduce the risk of transmission in the community to females and so on. So I do hope that we will work on a screening or vaccination, school-based vaccination program for the boys, like what they did in Australia, where they've introduced a school-based vaccination for the boys, and the boys also got vaccinated. Thus, they managed to achieve, they are going to achieve eradicating cervical cancers because of that, and because of the herd immunity that gender equality vaccination gives. The HPV, I think we have all seen this, how its configuration is. So let's talk about the oncogenic high-risk subtypes. I'm not going to talk about the low-risk, I want to talk about the high-risk subtypes, 14 of them, 16, 18, 31, 33, 35, 39, 41, and as you can read, so on, all right? And as you know, 16 and 18 are the most carcinogenic. So these are the 8 most common HPV types in cervical cancer. So 16 and 18 makes up about 75%, followed by 45, 31, 33, all right? How it gets infected is basically through sexual intercourse. Abrasions in the cervix, in the squamous colon junction, causes the infection through the basal membrane and the HPV virus to linger on at the squamous SCG or the transformation zone, all right? So the reason why women harbor the virus for long periods is because of the cervix and because of the transformation zone. They have a very large transformation zone. So what I mean by the transformation zone is the area between the original SCJ, all right, the original SCJ and the new SCJ, right? So the old SCJ, the original SCJ will start moving outwards as puberty occurs, right? And then the new SCJ will start forming. So it's the area in between that, that's where the HPV virus will linger, and that's where they will cause changes in the cells from normal to dysplastic to precancerous and eventually to cancer. So it's this huge area. So women who are on oral contraceptive pills, women who are pregnant, people with high estrogen, they usually have a very huge SCJ or huge transformation zone, or what sometimes people call it an ectropion. As you can see here, so this is the new one, and that's the old one, and this area is called the transformation zone. So anybody who's doing a colposcopy will always tell you you need to focus. Most of the times, this is where the changes will be. All right, it will not be in the columnar cells, it will not be in the squamous cells, it will be around this area when you do a colposcopy. So estrogen stimulation, like pregnancy and OCP, results in a large SCJ. That's why people say oral contraceptive pills are a risk factor for cervical cancer. Prolonged OCPs, use of OCPs, it's because they cause such a large squamous colon transformation zone, which gives the HPV virus a bigger chance of inhibiting and getting infected, right? Mouth cancers, vulva, vagina, basal cells, they get abrasions, they can linger there too. So, as we know, there are 100 subtypes. It basically affects the cervix, as mentioned, the SCJ. It affects the basal layer. And as the virus replicates, it changes layers. All right, as it heals, it changes, it integrates into tumor cells, and from bottom up, you'll get low-grade changes, high-grade changes, and it'll be CIN1, CIN2, and CIN3. But the process takes years. All right, the process takes years. It's much faster when you have 16 and 18 and you have a higher risk when you have the carcinogenic. All right, virus abrasion in the skin of the cervix inhibits, replicates, heals, and it changes. So it takes about 2 to 10 years. All right, it takes about 2 to 10 years. So who are those that are high risk? As I mentioned, is persistent infection. That's the one that you want to catch. All right, you don't want to go once in a transient. All right, and that's why we try not to do HPV testing in those less than 30, because we know that they most likely will be infected with HPV. They most likely will have good chance of clearing the HPV and thus not having any risk of developing cancer. It's the ones which are above 30, which are in a stable relationship, monogamous relationship, single partner, and the HPV does not go away and it's persistent. Those are the ones that we need to screen and catch them early. So what's the lifetime risk? I told my patients 80%. 8 people in the room. If there are 100 people listening to this, 80 of y'all probably got HPV or probably had HPV and now cleared it off. All right. Most HPV infections are asymptomatic. You will never know you had HPV. All right. Until today, I do not know I have HPV, but I've been vaccinated. We got the quadrivalent and also the nanovalent. So I think I've got a good chance of being protected, but who knows? As I said, persistent infection with oncogenic HPV subtypes, the 14 high risk will lead to it. So these are the 12 HPV subtypes that are carcinogenic, plus the other 2 that I mentioned earlier. So let's talk about Malaysia in our Malaysian context. 16 and 18, we know, fantastically high, but surprisingly 52 and 58 are the most prevalent HPV subtypes. And it's true. If you screen patients in your corporal clinic or those, I do see a lot of 52s in my clinic compared to the rest of them, and 58 too. So in Malaysia, you probably see a lot more 52 and 58 compared to the rest of the world, where you see a lot of 33 and 45. So this, they looked at those patients with high-grade dysplasia or AIS, and you see in Malaysia, 16 out of 40%, surprisingly 52. So in my practice, I just don't call. So a patient does a HPV DNA test. If they're 16 and 18, they go for colposcopy. But I also colpo those who are 52, all right, because of its high incidence of having dysplasia, all right. So technically, most guidelines say 16 and 18, you need to colpo straight away. Other high-risk subtypes, you can repeat if the smear is normal. But in my practice, 52 or so, I tend to colpo them a bit earlier because of this, all right? So 58, 18 comes up, and these are usually associated with adenocarcinomas. So this is the prevalence of HPV 16 and 18. If you have a normal cytology, your prevalence of having that virus is so low, right? But if you have a high-grade lesion, your chances are almost to 50%, all right? And if you have cancer, it's definitely 90%. All right. So this is why this is the logic behind, rather than doing a pap test or doing a pap smear, it's better to check doing a HPV DNA. Because if a patient has got HPV 16 or 18, I can tell her that she's got 50% chance of having a high-grade dysplasia. That's why we colpo them immediately. All right. And they've got the high risk of developing cancer. So that's the rationale why 16 and 18 we do colposcopy, irregardless if they have a normal cervical cytology. So the subtypes, as you can see, 52, very high, 68, 58. These are in cervical vaginal swabs, all right, and 18, all right. So keep in mind, in Malaysia, 52 and 58, very prevalent. Among positive women with CIN2 and CIN3, again, same slides showing the prevalence of 16, 18, and 52. 10 most frequent. The 10 most frequent are about similar all over the world. It's just the arrangement of the subtypes. All right, 16 and 18 always in top 3. Ours 52 comes in second. So we do understand that it's persistent carcinogenic HPV infection that will predict the risk of cervical cancer, right? So if they ask you who's at risk of developing cervical cancer, is not those with HPV infection or high-risk HPV infection, is those with persistent high-risk HPV infection. Why is this important in clinical practice? So I get a patient referred for high-risk HPV. Pap smear is normal. It's not 16 and 18. So I always check back and see whether she had a previous HPV DNA test done. If she's done one in the last 2 years and it's negative, so I do know that that infection is just recent, right? So I'm not too worried because it's not persistent, right? But if she had a high-risk HPV since 3 years ago and that high-risk HPV has not cleared, then that would increase the risk, even though her smear is normal. So it's persistent carcinogenic HPV infection that predicts the risk, all right, of developing cervical cancer. So the virus is usually cleared off within 12 to 24 months. All right. I usually tell patients 2 years, especially those with high risk HPV. The low risk HPV usually takes about 18 months, 12 to 18 months, but the high risk I usually give about 2 years, as long as the colposcopy is normal, as long as the smears are normal, especially the young. All right. So this is another take-home message, is that give it time for the virus to clear naturally, because it usually takes about 12 to 24 months. I've seen patients takes about 3 to 4 years, but they eventually clear. All you need to do is just to keep an eye that they do not have dysplastic changes in the cervix. All right. So as said, the major determinants of HPV persistence are HPV type and viral load. So we know type, highest risk 16 to 18, colpo. The rest of the 14 high risk subtypes, you can always do a reflex, pap smear, normal, send them back. Come back in 1 year. Another key point is the viral load. Right? Why the viral load? We can't quantify HPV viral load, but we know that the viral load in certain patients will be high, such as those who are HIV, immunodeficient, those on steroids, cigarette smokers. So I have seen, or I do have patients which are newly diagnosed with HIV, come back with HPV, but once they start treatment and the CD4 count goes up, the viral load comes down of HIV, the HPV tends to clear. All right. So these are those. The viral load is important when you start treating those immunodeficiencies or patients with HIV. So those patients with HIV, they should have a HPV DNA or a smear done every year, because they are very high risk of developing precancerous changes. But how do you manage them is based also on your CD4 count and your viral load. As long as the CD4 count is good, the immune system is good, they have a good chance of clearing off the virus of HPV. Cofactors that increase the risk of progression are like smoking, as I said, and other STIs. So the cervical transformation zone is where everything happens. I think we all know that. I just mentioned it's the area between the original and the new. And this is how it infects the basal membrane, the basal layer, multiplicates, interacts with the cells, starts moving up, takes over. It's like an alien, takes over the whole planet. And once it breaches the basal membrane, it becomes cancer. So this is what we don't want. This is where we want to treat. This is where we want to catch them. All right. We do not want them to go to CIN3. All right. Another take-home message: CIN1 and HPV infections are basically almost similar. I always tell patients, if you have low-grade dysplasia, basically means you got HPV. All right. Nothing to worry about. We'll just keep an eye on it. You have a good chance of clearing it. You got a good chance of it going back to normal. All right. So CIN1, I always associate it with just HPV infection. All right. But when they have CIN2 and CIN3, that's when they've got a bit of higher risk of going into and developing cancer. So you probably would like to offer them some treatment or closer surveillance. So transient infection, persistent, becomes persistent, changes to precancerous. Keep it longer, it becomes cancer. All right. Transient infection, not really a problem. Most of the time, it reverts back as you clears off the virus. So this is where we want to catch them. This is where we want to detect them. We want to treat them so they do not progress to cancers, right? We do not want to do radical surgeries to increase their morbidity. We want to do minimal surgery so they have less morbidity, all right? Just to clarify about the pap smear. So a lot of people come and ask me, why did why does the pap smear shows low seal, high seal, and what is the difference? All right, so it has changed from 2013. Now we're using the 2014 Batista system where the ASCUS, ASCH, low seal, high seal, SCC, and then comes the glandular components. All right, so you just understand that the smear is a cytology. All right, basically what they detect is abnormal cells. The dyskaryosis, low grade or high grade, abnormal cells. Histology is tissue diagnosis. Tissue diagnosis can tell you CIN1, CIN2, CIN3 because they can look at the levels of the cells in the base, from the basement membrane upwards. CIN1, CIN2, CIN3 is a histological diagnosis. Low seal and high seal is a cytological diagnosis. Cytological means they look at cells. Histologically, they look at the whole component of tissue levels, cell levels, right? So I'm just explaining things that a lot of the primary healthcare workers will ask me, or my junior specialists will ask me, or MOs will ask me is, okay, ASCUS, what would you do now? My practice of ASCUS, I usually do if she reflects HPV DNA because we have it in my hospital, and if they are 16, 18, I do a COP. If there are other high-risk subtypes, I just repeat it in a year, 6 months to a year. If they're negative, just go back to, repeat it in 1 to 2 years in ASCUS. The problem comes with ASCH, right? So ASCH, what is ASCH? Is atypical cells of unintimate significance, but cannot exclude high seal. So what I will always explain to my medical officers or specialists and to patients that ASCH basically means you have low-grade changes and also high-grade changes, right? Means you've got a high chance of having a high-grade change, which is about 25-30%, and you most likely have HPV. So for me, if you have ASCH, you should do a colposcopy. I would not advise against doing it. You can do a reflex, you can do a HPV DNA, but regardless, if I do have ASCH, I usually will recommend to do a colposcopy because most of the time they have a mix of a low-grade changes, high-grade changes, which you detect. All right, low seal reflex HPV DNA. You can always repeat in 6 months to a year. You can also COP them if you have the facilities, right? And then comes the glandular, all right? So this is what, if you don't treat, they will become early stage cervical cancers, which are still treatable with surgery alone, all right? But we will try not to get there. So that's why we're urging that the screening and the treatment be done in the precancerous stage. Again, to reiterate, normal, infected works the way up, all right? Smears only detect abnormal cells, high nuclear cytoplasmic ratio, mild to moderate dyskaryosis. But biopsy will tell you whether it's CIN1, CIN2, CIN3 because they take the whole tissue layer and they can look at the levels and see how much of it has been infected or changed by the HPV virus. All right. Cytology only shows dyskaryosis. Biopsy shows histology. All right. So this is the likelihood of regression because a lot of people ask me how do you counsel patients. CIN1, 50-60% definitely will regress, especially if they do not have high risk subtypes. Don't have to worry about them. CIN2, 40%. So 40% is actually a good number, especially if you get them in the young. So now if I have a young patient with CIN2, I try to become more conservative because we know 40% of them will regress. We know they're still in a young age group. They have a good chance of clearing the virus. If I have an elderly lady at 60 years old with some comorbids and she comes with CIN2, I would treat because we know that her immune system might not be as good as the young ones, and she's most likely will not clear off the virus on her own, and it will progress to CIN3. So that's where you just need to do a bit of weighing the risk and benefits, and think about it, and what's the risk of this becoming CIN3 and becoming cancer. All right. So take-home message from the first session is that most common sexually transmitted infection is HPV. So 80% of us will get it. So don't be alarmed if you have it. You will definitely get it when you get married. You have them, but we know that it's only an infection that can be cleared off. Out of this 80%, only 10% of it will be persistent, and that 10% is the one we need to catch, we need to screen, and if needed, we need to treat. All right. The key is persistent. Persistent prolonged HPV infection will lead to cell changes, leading to precancerous lesions and finally to cancer. All right. So that's the take-home message from, I think, our first session. I think we're due for a break, so I shall pass it back to Dr. Murali.
Thank you so much. I'm just wondering whether you have any questions, and we're looking at that. Doc, I just had one question immediately which popped up, and one of the things that you were speaking about just now is persistent infection. So, and I'm sure you did mention that in terms of how do I actually determine that this is a persistent infection, you know. So would you mind just kind of putting that again back to everyone?
Right. Yeah, okay. So it's HPV DNA, I think in Malaysia, it's been there quite some time. I think we were looking at it as a screening tool about 10 years ago. I will explain to you later. Yeah, but now it's becoming more popular, more awareness is being about HPV DNA. People are coming and asking for it. Okay, so because we know the culprit is HPV, we know that's the one that causes the cell changes. It's the persistence of it. So I get a lot of referrals for high risk HPV coming to me for colposcopy, and I need to weigh whether they actually need because some of them are young, some of them are just got married, they're about 30s, they're about 28, they tend to do, and I see whether I actually really need to colpo them. So I look back and see, have they ever done a Pap smear before, whether they've done a HPV DNA before, and if they have and it's negative, and I tell them, this is probably something new, it will clear off, right? Not to worry, we will just keep an eye on it. You can repeat it in a year. Just, if they're very anxious, there's always a chance of doing a reflex testing, which in my practice we do. We do a HPV DNA, and then if it's high risk, H16, 18, we should record them. If it's other high risk subtypes, we just do a reflex, So the key is there is persistence. So how do we determine whether it's persistent? It's looking back at the previous smears, looking back at your previous sexual history. They've been in a monogamous relationship for the past 5 years. All right, and now the first time they're doing HPV DNA. So, okay, so probably the risk of having the HPV is, not that really high compared to someone who just had multiple partners, your new partner, and then getting the infection. So it's about the risk of having that persistent infection. The hard problem I have is that always they come, and once they have HPV DNA high risk, they don't want to have sex with your partners. I don't know whether you got this question. That's the question that I get the most of the times. Where did I get the infection from? Did I get it from my partner? Did I get it from my husband? Did I get it? As I said, the question, I think we have got to get away the stigma. The stigma is that I'll ask you this back, Dr. Murali. What do you think? Do you think HPV is a STD? Is it a sexually transmitted disease, or is it a sexually transmitted infection?
I would definitely go with infection rather than disease.
Yes. So that's what I want to try to clarify, because when you work in private and you apply for insurance and all that, the insurance companies will tell you whether is this an STD. And I will say, no, it's not STD. A disease is something that you have and you can't get rid of and you need to take medication to treat. But this is an infection which will naturally resolve. All right. So it's not a disease. It's something that everybody of us will get. So I think we got to get that into people's mind. It's something that we will get it. It's not your partner's fault. It's not your fault. You will clear off the virus. Continue having amazing sex. Don't let it deter you. The fear is that after I treat them, they don't want to have sex because they're worried they're going to get, and I'll tell them it's not going to happen. Why? Because after you have cleared out the virus, you will have antibodies against it. Natural antibodies. All right. I can't test your husband whether he's still got infection, but he too will have natural antibodies. All right. So please don't leave him, don't divorce him, don't find a new partner. No. All right. It is naturally normal. That's the stigma that always I have, so that's something I'm trying to explain to people, and to explain it's not a disease. You don't need medication to treat it. It will go away naturally. So it's just a transient infection. Most of us will get it. But the key there to treat is persistence. If I get a patient, HPV DNA, previously 16, normal smear, now 16 or 18 or another high risk subtype, normal smear, I will still colpo them because it's been 2 years and they haven't got rid of the infection. I'll be worried. So when do you treat and when you not treat? So as I said, if they're young, give it a good time. If they're older, even after 1 year, comorbids, they might not clear it. All right. So you need to assess. It's a personalized treatment. Each individual very different. Even with the same subtype. So the key there is persistence of HPV infection. You need to analyze. Yeah.
Absolutely. Thanks, Doc. Doc, there's a couple of questions as well. The one is from another colleague who asks, look, I've got patients who are asking me, when you ask them to do a HPV DNA and then comes back for either one of those high-risk subtypes, then you ask them to do a pap smear in some cases. So what the patient's pushback is, why then you ask me to do an expensive test, now you're asking me to do a cheap test? Why couldn't we have done the cheap test first and the expensive test later? Any thoughts on this, and how do we speak to patients about this?
Right. So there's two approaches to it. All right. In most of the time now, when you do a HPV DNA, you send it to the lab, and if you send it to Pantai lab, they will, if it's a high-risk subtype, they will keep the sample for you for a certain duration.
Right.
So you have the option of doing a reflex smear test. Okay. If you're just doing a pap smear test, like most of the government hospitals, but like in MRCoG now, we just use liquid base. If the pap smear is abnormal, the lab will keep the results, keep the sample, so that you can do a reflex HPV DNA. So most labs, that's the practice nowadays. So the patient does not have to go and get a repeated smear.
Right.
Okay. What is good for your patient? If this is the first time, I will do a co-testing.
Right.
All right. That means you do both if it's the first time. All right. To analyze her risk. This is about risk assessment. All right. Smear might be normal, but she might have high risk. So
absolutely.
Basically, I tell them the first time you come, you want to do a screening test. I said we're going to do a screening plus a risk assessment of your risk of developing cancer. So we do co-testing. So you send them both, and most labs have jumped on board. The price is about the same. I think now Pantai lab. So now if you do high, because basically it's the same bottle, it's just the testing. Yeah, last time there was a bit of price difference, but now I think they've come down and they've realized that co-testing. Yeah. Okay.
It's the way to go.
Yeah, exactly. Only those who have had smears before, normal, and then they come back to me and then second time I said, why just do a HPV DNA? You're negative 5 years. You don't need to do another smear if you want to. Yeah, but most labs now offer both the tests for almost the same price. All right, so you don't need to pay again. All right, primary screening for the country, HPV DNA probably is the way to go. And if they keep it, yeah. So like UK, that's what they do. They do HPV DNA, reflex pap smear. In Malacca, it's opposite. If you do smear abnormal, then we do reflex HPV. So I don't know where the country, which one, but I think Malaysia is probably going towards HPV DNA as a,
we're inching towards it, but I think cost is
yeah, that's the only thing, cost. But I see a trend of it coming down.
Yep.
So I think the labs have understood that the more people we do,
the more cost effective it becomes.
Exactly. That's the concept of how every even drugs, you make it more available to everybody, more people purchase, it comes lower down. So that's the concept that we need to jump on board and, so you don't need to tell your patient you're doing a cheaper test. You're just telling them, you're just taking it and sending it again. And I think most labs have understood that.
Right.
They would do it together, yeah.
Got it, Doc. We have some questions coming in now. Okay, so the first is, I think, on what we were speaking about is how often do we do HPV DNA testing for a patient?
Okay, so if you do a co-testing and both are negative, every 5 years. If you're just doing a HPV DNA negative, you can do it to 3 to 5 years. All right. I think most studies have shown 3 years definitely safe. Some says 5 years. For me, I will do a co-testing. Only with co-testing negative, I ask them come back in 5 years. 5 years. Because it takes a lot of time for it to progress.
Okay. Another question from a colleague on, is there an age limit for getting the HPV vaccine?
Okay. So the vaccine has been approved to the age of 45. If you, technically it's under 25, but some women after 25, 26 to 45 can get the vaccine, but basically on a case-to-case basis. So is there an age limit? I'll be talking about it later on in the second session about it. Okay. The vaccine is only probably until the age of 26. The reason being because most of them by 26 will be sexually active. You probably got some HPV infection. The vaccine won't be so efficacious for you. But saying that, I have vaccinated patients above the age of 26 My oldest patient I vaccinated was 55. Reason because she was being infected with multiple subtypes and causing problems. All right. So after being treated, it's another subtype. After being treated, subtype she was she's diabetic and all that. So I vaccinated her. So it can still be given after the age of 45, but it's on a case-to-case basis. All right. And another thing, please, I mean, it's a person, maybe a personal preference. Do not vaccinate a patient who's already got HPV, if you can. So before I vaccinate someone, I'll always do HPV DNA. If they are positive for even one of the subtypes, I let them know.
Right.
Don't get the vaccine, clear off the virus, then especially if they're in a monogamous relationship. Because I get a lot of referrals. Patients, I think 50% of most of my cervical cancer patients will say that, hey, I got my vaccine.
Yeah.
Or why did I get cervical cancer? Or why did I get precancers? Because you were already infected.
Yep.
Before you took the vaccine. Yep. So a lot of them will argue, no, but you can protect against other subtypes. Yes, but you're not benefiting the patient.
Yep.
She's paying so much money, and she's eventually going to go for treatment for precancer changes. And that's my point of view. Yeah. So I tend to test them before I give them the vaccine. So I do a co-testing, negative, take the vaccine, you're good. You know,
okay.
Yeah.
Got it, Doc. So another question on if an individual gets infected, then clears off a subtype. For example, 16, are they still susceptible to the same subtype subsequently?
Technically, if they get infected and they clear it off, that means they've got antibodies towards the subtype, right? So 16, I would say, in my personal experience, I've never seen a patient get reinfected with the same subtype after they've cleared off the virus, all right? The only people I've seen that tend to get infected with the same subtype are those, yes, because the antibody levels are not high enough to cope with the viral load. All right, so that's, I've seen those with chronic kidney disease, those on HIV, I've seen them get reinfected with the same subtypes. Even some smokers or so, I tend to get them come back with the same subtypes, you know, because the antibody levels that they have, which they develop, are not high enough to overcome the infection that second time around. So those are the patients that can get reinfected with the same subtype. But immunocompetent patients, people are fine.
Lovely. Doc, any antiviral drugs that can cut short HPV persistence?
It's in the works. All clinical trials, they're looking at it. They're looking at it. Yeah, you know, they're even looking at it, treating CN2 and CN3.
Yep.
You know, and they've shown some benefit, 30% regression rate, and I think it is possible. Yep. It will become possible to have therapeutic vaccines. Now we're just giving prophylactic vaccines.
Prophylactic vaccines.
Yeah, but it's not that. So that's another concept, right? I get a lot of patients coming to tell me, you know, the GPs tell me or the doctors tell me that, you know, you take the vaccine, you know, your CIN 2 or 3 will go away, you know.
Not yet.
You will be amazed of the thing. And no, just take another take-home message. This is a therapeutic vaccine. It will not treat your precancerous changes. It will not treat the infection that you already have.
Yep.
All right, it's a prophylactic, but the works they're targeting the Ki67, they're targeting the mRNA, they're trying to reverse it. So all clinical trials, good results, especially for CIN2 and CIN3. All right, the latest trials, I think the drug shows about a 30% to 40% regression. So we're trying, you don't need to do a cone or you don't need to do a LETS. All right, so these patients comes, you give them the therapeutic vaccine, you see them back in 6 months, 3 to 6 months time, you can see the regression. Right, but only what they're working out, is it due to the vaccine or is it due to the natural regression of it? So that's why it's taking a bit longer than to come out. So it's exciting. You know, the might not need to do another cone. Yeah. So you know why? Because I've got Australian fellows coming to Malaysia now to do word times.
Oh wow! Okay.
Yeah, I just got an email from another because I worked in Australia, so I got from another CGO colleague of mine asking whether his fellow can come for 6-month attachment to my hospital in Malacca or wherever, and just do word times, because I do word times about 4-5, you know, per month of you know, word times, and so I said, yeah, come over, you know, because you will never see another word times in Australia.
Yep, not anymore lah.
It's
a good thing. It's a good problem to have. You know, yeah.
True, and it will come a point where you don't need a colposcopy anymore.
Yeah. Yep. Exactly.
Which is good. Yeah.
So a colleague asks, how long does the infection has to be there before considered to be persistent? And I think you spoke about this.
Low risk, anyway. 12, yeah. Low risk, 12 to 18 months. high risk, I always give it 24 months. Give it at least a good 24 months. But also depends on the patient. Young patients, I tend to wait longer because they have a higher chance. Older patients with comorbids, I tend to be a bit more aggressive because I know it will be harder for them to clear the virus. It will be easier for the virus to progress. So usually low risk HPV subtypes, 16 to 18 months. High risk, I usually wait about 24 months. But during the time you wait, you need to keep an eye on it as long as it doesn't progress. Yeah.
Right. And just to clarify, Doc, that means you retest at that period, yeah?
Yes.
Absolutely.
Yes.
Okay.
Yes.
Just making it crystal. Okay. What is this? Question on how regular should we get HPV vaccination? Once in a lifetime?
Once in a lifetime, get a good one. All right. Okay. I had it twice, but because I had the 4, the nanovalent, and that was early on 2013, 14, and then after 2015, 16 came out the nanovalent, and I had it in 2017. I got it. So you only need it once in your lifetime. All right. Right now, I think the quadrivalent, they're going to stop production. So it's only the nanovalent, the 9 subtypes.
Yeah.
And I think the bivalent is still available in Malaysia. I think UK, I think the company is starting to start producing it because they feel that, when you got 9 and you got 2, it beats. So right now, there's only probably soon we need the bivalent and nanovalent. You get the nanovalent, you need it once in your lifetime, you're set for life. Yeah.
I'm pleased to be able to share this generic quadrivalent coming onto the market. So. Doc, the 2 questions very relevant to whatever we were just talking about. First is, if patient was vaccinated with quadrivalent before, can they still take the nanovalent? And the second question is, nanovalent vaccine available in Malaysia?
Okay, first question, I'm living proof that you can be vaccinated again, right? So I had the 4 and now I got a 9. Why? Why did I take it? Is because it protects against from 70% protection, 75%, you get up to almost 85 to 90%. All right. It's fantastic. Okay. So it protects against an extra 5 subtypes. All right. Your protection against the original 4 types might not be as good, but against the 9. So you've got the nanovalent, your protection goes up to 98%. As years go by, it wanes down. So now you got protection against the 4 subtypes about 90%. Then you take the nanovalent, and it goes up back again to 98% for the other 5 subtypes, but your 4 subtypes will still remain about 90%.
At about 90%.
90%. It will not shoot up.
Right.
So you still can be vaccinated against, and it will still carry some benefit. All right.
Exactly.
So
yeah, you're saying, Doc.
If so, anybody comes in, I got vaccinated with 4. A lady comes in, should I get a 9? I say no. All right. Let's assess your risk. If you're a stable relationship, you've already got the vaccine, your smears are normal, you're negative with DNA, you're not going to get a new infection. So you need to assess the patient's risk. If you're single, young, you feel like you're traveling, you got multiple partners, you're a smoker, all that, yeah, you get, because you're higher risk. So it's all about risk stratifying the patients and whether they should get the nanovalent. Yes, the nanovalent is available in Malaysia. 3 doses, 0, 1, 6. 0, 1, 1 month and 6 months. It's available. You can get it from government, private. Yeah.
I don't think you can get the nanovalent in government though.
Government, sorry, not government hospitals, but government LPP can.
Oh, LPP can, you can buy the 9.
You can buy it. I mean, it's not free. Trust me. So sorry. It is not free. So Murray got a bit worried. After this, people might be coming. No, it is not available for free. You still have to purchase it, regardless whether it's in the government or government department like LPPKN, the Family Planning Association, or in the private. Right? You still have to pay for it.
Absolutely, for the nanovalent.
Murray, I don't know you, but can I have a question, Murray?
Yes, please, Dom.
So I was reading and I was talking to a colleague who works with the HPV task force and all that. We're looking, I think, to change the school-based vaccination to a nanovalent maybe in a couple of years, because they showed that they did a study and they showed that it's more cost-effective and in terms of that. Is that true? The rumors?
Yep. Because currently I think we're still using the bivalent. And I'm not sure whether during what I was also told is, I'm not sure whether during the entire COVID-19 crisis that we actually have been vaccinating those cohorts. So we may need to catch up on that.
Exactly. We lacked a bit. Yeah.
So we're trying, I think, again, it becomes a cost efficiency issue, but I think we're also getting good good responses from the industry saying they will support like an equal cost to cost.
Fantastic. Yeah.
So hopefully that takes off as well, Doc.
Good.
Okay.
That's amazing.
Oh yay, we have actually completed this series of questions. Shall we? Can I give you back the floor?
Cool.
Oh no, I've got one more. Could I just give you one more?
Yeah, sure.
Okay. What is the durations of antibodies in our body, either by immunization or infection against virus-specific infection? Is it lifelong?
Okay. So the studies they have done with they started off with the quadrivalent, and then they moved on with the nanovalent. And so far, we've got about 20 years worth of data. And so far, the immunity with the vaccination has been maintained, and it's above 80%. I mean, it will wane down depending on individuals, but the immunity is still there above 80% even after 20 years. So for me, if someone asks me, I say it's still lifelong, right? Once you develop, you take the vaccine. How about natural? Natural clearing of the virus, as I said, the studies have also shown once you develop the antibodies, it's much better and it will last for life, except for those who are immunocompromised where your antibody levels starts to wane. All right, you do not have enough thing. But if you develop naturally, it's highly unlikely for you to not for the antibody levels to wane, but it won't be as good as getting a vaccination. So someone tells me, okay, I've got 16, I've been treated. How do I test I've got antibodies against 16? Mm-hmm. It's a bit difficult to test whether you got antibodies against 16, but you're highly unlikely to get infected with 16 because you will have a natural body. So it's hard to check for natural immunity. So then they ask me, then should I take the vaccine for 16? So that's when you say no, because it comes in a package. So you might not be protected against 16, all right? You might not be protected against 18, because I've seen a lady at the most with HPV DNA, I've seen a lady who had all 14 high-risk subtypes.
Right. Oh, wow.
It's amazing. I framed it up, all right? Because I'm not sure it's true or not, right? But literally, she had all 14 high-risk subtypes. And she came to me because she had changes, obviously. And I treated her. And after treatment, I repeated the test. And she still had HPV infection, but she had it for only 2 or 3 of the high-risk subtypes. So then she tells me, should I get a vaccine? I say, yeah, you should get a vaccine. I mean, because there's always this cross protection and it will increase your immunity. The vaccine, it means the natural immunity. So she took the vaccine, and after that, she eventually cleared it off. So I still do believe that getting the vaccine, even though you've got antibodies against certain subtypes, is beneficial because of the cross protection to other subtypes. Right. Yeah, so it is a lifelong take-home message. It is lifelong. You just need once in your life. It will last. I have not seen anybody except for those who are immunocompromised. So those who are HIV, who have been reinfected, I tend to repeat the vaccine if they have good antibody levels. Yeah. If their antibody levels are still weak, we do not vaccinate them. Right. Once they pick up the antibody levels, they're in good remission. They think CD4 counts are great. I tend to vaccinate again.
Got it, Doc. So thank you so much. I think I think there's still 1 or 2 more questions, but what we'll do is we'll take it right at the end in the interest of moving the session right along.
Thank you,
Doc. Back to you.
Right, back to sharing screen. Let's go. Okay. All right. So to session number 2. Yes. Let's talk about. Okay, can I move it? Share screen. Okay. So what we're going to talk about session 2 is basically about primary prevention, secondary prevention, and what are the challenges that we are facing in Malaysia. All right, because I'm hoping, and I think everybody out there is hoping, that eventually we will eradicate cervical cancer. I mean, it would be great. I mean, I might be out of a job, I might be working less hours, but it would be great to see cervical cancer being eradicated. So wait, I'm trying to move my slide. All right, good. Okay, so yeah, Australia, the first country to eradicate cervical cancer. I was there in the process where they were in the midst of it, you know, and it's true. It's really true. I mean, I was doing. I don't think I can't even remember if I did a radical hysterectomy for cervical cancer. Maybe I did one when I was there, but that's how good it was, you know. We might take a bit longer than Australia because Australia vaccinated the boys. Right, we're going to have a bit of problem because we're not vaccinating the boys. I hope that changes. I hope the boys are vaccinated in schools because of the gender equality and the herd immunity, you know. So those parents out there who are listening, or doctors, you know, if your GP practices, get the young boys vaccinated because you'll be protecting them, protecting a lot of girls too from getting infected and reducing the risk of cervical cancer. So we know it's yes, so definitely yes. All right, how? Primary prevention, secondary prevention. HPV vaccine and preventing individuals from getting infected. That's primary prevention. You know, we got a good vaccination. So why we're winning is because we've got a good vaccination program. Our vaccination program is school-based. We get them young. We cover about 90% of all of them. The parents are very supportive of it. And now what we need to do to win this race is improve on our secondary prevention. We need to start screening for individuals who are infected, but not just infected, but those with persistent infections, especially. And then we need to catch them, screen them, and treat them, especially those with high-risk HPV or abnormal smears. So we all know the vaccine, all right, that how it works. It's basically a viral DNA. They take off the virion, they put in a harmless one, it reproduces, our body recognizes it, creates some antibodies against it, and it's lifelong. All right. The vaccine, right now, the school-based one, as you say, is a bivalent. If you're less than 15 years old, you get 2 doses. More than 15 years old, you get 3 doses. Latest studies have shown that you only need 2 doses actually if you're less than 18. Even until 18, you can still just go with 2-dose vaccination. Just to brief what we have in the market right now, we have the Cerverax, the 4 and the 9. 4 is going to be outphase. Cerverax still around, 16, 18, basically covers the high-risk carcinogenic types. And we've got also the 9. So our school-based vaccination, we have been promoting it. You know, as you said, if you're less than 15, you get 2 shots. You're more than 15, you get 3 shots. Hopefully in a couple of years, you'll be 18. All right. We started in 2010. It became a school base for all Form 1 girls from 13 years old getting vaccinated. 2 doses for those, 3 doses, highly efficacious. So we have a pickup rate about almost 95%, 92 to 95% in West Malaysia, a bit lower in Sabah, about 75 to 80%. But we're picking up. We are picking up. If you look at this, all right, from 2010, we've actually been quite consistent. 98% who received the first dose, almost 99%. You know, who also completed, you know, the last dose. What we find is that a lot of them do not complete the course. All right, especially once they need a 3-dose schedule. The 2-dose schedule is not too bad, but the 3-dose schedule, a lot of them do not complete the course. So you see, we achieve quite a good rate, but then, you know, the numbers start to wane after, you know, when to complete the 2nd and the 3rd doses. All right. So this is where we need to, you know, especially now with the COVID happening, we have stopped. There's a big catch-up group that we need to focus on. So other than school-based, we should do opportunistic vaccination. So my patients, their daughters, I offer them vaccination. If you know the less than 15 years old, I give them 2 doses. More than 15, we give them 3. And I tend to promote the nanovalent, you know, just for 1 shot for lifelong. Yeah. So 2 ways to protect yourself, as I said, vaccination and screening. So a lot of them ask me, if I'm vaccinated, why do I need to screen? As I said, the vaccine protects against 9 subtypes. It gives you a protection level about 90 to 95%. But we know there's also a small percentage which is non-HPV related, which can cause cervical cancer. We know there's about 5% of them which are not covered, 5 to 10% which are not covered by the nine subtypes. So your chance of having it is still there, might not be as high as someone who's not being vaccinated. Secondly, your antibody levels may not, if you've got comorbids, your antibody levels may not be as good as someone who is healthy and well. So even dwindling antibody levels, you might still get an infection. All right, even though they say that antibody level more than 80%, but that's in a community, that's a large group of people, and studying is a bell curve shape, so you might not be in that group. So I always tell patients you still need to be screened. All right, even though you're vaccinated, you still need to go for screening. So there's a lot of myth that I'm vaccinated, I'm safe from cervical cancer. No, you'll be amazed at how many patients I've seen with precancerous or cancerous lesions who have been vaccinated. All right, and so it reduces the risk, but it does not eliminate the risk of being vaccinated. So a lot of times we talk to the parents about it, about the school-based. So far, I think in Malaysia, we have not really had a problem in the school setting about telling them about why they need the vaccine and is it safe, you know. I think we've done a good job as evidenced by our pickup rate. But for those of you that in practice that want to talk to parents about it, you know, you can always print this out from CDC government, paste it up, you can blow it up, you know, they can read about it. And it basically covers every aspect that a mother would ask about her daughter, or why do the boys need the HPV vaccine? So you see, HPV vaccine can help prevent future infections that can lead to cancer of the penis, anus, back of the throat in men, which is rare, but more so it prevents the community and the herd immunity, the transmission of to other females, right? So it's a good article if you want to print it out from CDC. So as I said, a lot of my common questions that I get about the vaccine, is there an age limit? No. License to 26, you still can license 25, you can use it after 25 from 26 to 45. After 45, case on case basis, as I said, discuss with your doctor or get an opinion whether the patient would actually benefit from it. So a lot of times I see a patient who has been diagnosed with abnormal smear, they do a biopsy, CIN2 or CIN1, then they give the vaccine. And then after 6 months, they repeat, it's still CIN1, then they refer to me and they say, hey, I got the vaccine, why am I not cured? Again, the vaccine is prophylactic, it's not therapeutic. I think it's a shame if you're going to give it to someone who's already got HPV infection, because she's not going to get her money's worth, right? So I tend to give only when those are HPV DNA negative or they've been treated, right? If you've taken a previous HPV vaccine or bivalent or the quadrivalent, you still can get some benefit from the nanovalent. No, it does not increase your side effects. How long should you wait? I've had 1 or 2 patients who have started on the quadrivalent, did not finish. They switched to the nanovalent, perfectly safe within the same year. Should you give a vaccine to someone who has an abnormal smear? No, unless you do HPV DNA. Abnormal smear of low seal with HPV DNA negative, you still can give the vaccine. All right. Can that happen? Yes. Can you have an abnormal smear? Someone asked, can you have an abnormal smear like a low seal or ascus, but you're HPV DNA negative? Yes. What does that mean? All right. I'll answer that at the end of it. Think about it. But they should be vaccinated. Should males be vaccinated? Definitely. I'm all for it. I think they should. I think it will help us reach the WHO goal of eradicating cervical cancer much faster. As I said, males are the biggest carriers of HPV, so they should be vaccinated. As I said, we've been looking at HPV DNA screening tests for cervical cancer since 2011. This was the technology assessment. So, but we have not really started it until of late. All right, we've had other tools to screen for pre-cancer and cancerous. So we're talking about secondary prevention, where we're going from vaccination, which is primary, now to secondary prevention, which I think for Malaysia is where we need to focus our resources. Pap smear has always been there, the conventional AS Petrula, all right, but I think we need to look beyond the Pap smear, because we have got other tools which are more efficient, more patient friendly, and more informative. All right. Pap smear started, I think, in Malaysia in 1995. Yep, was suspended. And even though we've had the program for the past 30 years, it has never taken a well response. I think the highest we've got, as I said, it was only about 45% uptake, you know. So WHO said that if you want to eradicate cervical cancer by 2030, you need to vaccinate 90% of your population, and you need to have a good screening program to screen for almost 70 to 75% of the population, which we are far behind if we're going to continue with doing pap smears. All right. So we've had it. Active intervention, no. We've not, so our pap smear screening program was always opportunistic. It started with the 6 weeks postnatal visit, which is kind of hardly done these days. So we never caught those. It was never a call recall system where we invited patients in that area to go to the nearest health site to do it. No, it was always opportunistic. As long as we keep it to opportunistic screening, we're not going to achieve what we intend to. All right. Our screening pap smear was always every 3 years. It started at the age of 20. All right. So this was what we have or we had. All right. As I said, we have not really achieved the coverage that we wanted. These are all the studies we've done, and the best also was about 45%. We've never achieved more than 50% of screening of our female population. Why? There are a lot of reasons. A lot of people are, if you live in the rural, like where I worked in East Malaysia, the lack of knowledge about the disease. Not many people know what cervical cancer. Not many people know what a pap smear is. The health literacy, especially in East Malaysia. In West Malaysia, I guess it's more the low perception of cancer risk. They think they're cervical cancer, not really heard of. Not really. We don't know much. Lung, breast cancer, yeah, everybody knows about breast cancer, but cervical cancer, not really. The behavior towards the preventive program, so preventive program of vaccination, but in terms of pap smear, a lot of women run away from a pap smear, and because they feel it's very intrusive, very medieval, very painful, right? So there was, and we did not have a call recall system. We were always opportunistic, and whenever you have an opportunity screening program, it's never going to be very successful because it will take the ownership or the ownership of the person who is doing the screening to ask the client whether she wants it. But once you have a program which is in place where everybody must do a system like what they have in UK, what they have in Australia, where GPs have to achieve a 90% coverage of that population, female population in that area, where they reimburse you to the GPs for covering the 90%, that's when you're going to get a better coverage compared to opportunistic. So we've got a lot of points that we need to work on, all right? And one of the main culprits that I think we can work on is this, all right? The cuscal speculum, the duckbill that people always talk about. I try not to use it in my practice. I do not like the cuscals because I think it's very intrusive. I only use it when I do colposcopy. For surveillance and follow-up, most of the time for my cancer patients, I just do a digital vagina examination with one finger because I feel it's more comforting, more less painful and less intrusive. So the duckbill is the source of all pain that women go through when they do a pap smear. Why? Because it stretches the vagina. All right. The vagina, yes, is meant to be stretched, but only to a certain point and a certain length or depth. But with the cuscals, you really can make it wide, and it causes a lot of pain, especially against the pubic bone, against the sacral bone. So this is one of the main reasons. And a lot of times people, women, when you tell them pap smear, they say no, none time, different time. They want some, Yeah. So we need to find a way where we can do a testing without doing a cuscals. So I'll talk about it later. And then we've got this conventional pap smear, which people still use on a slide with a stick. For me, I still think it's we don't use it in Laka GH. We're moving away we're just doing liquid-based because the reason why it's very medieval, using a stick to try to scrape cells off an anatomical part and then putting it on a slide and then spraying it with alcohol and then sending it. It's tedious, it's medieval, and it does not give us good results. And that's been proven. It's good sensitivity pap smear of 50 to 55%, but it's not constant. It's very operator dependent. It's very taxing. All right. So my view and my shout out to everyone is that try to move away from conventional pap smears with a slide and go towards liquid-based cytology, which is much easier to do. You do not need to visualize the cervix much. You just need to get the cervical vaginal fluid, and that's more than enough. And they can read cells from that, right? Timing on pap smear, I think everybody knows this. So these are the types of pap smear tools that we have, all right? So we only use this in the conventional smear, which we're trying to phase out, all right? We do not want to use this anymore. We only want to use this, all right? And this is what we use in the liquid-based cytology, LBC, all right? This is the brush, this is the broom. I'm just going to explain this because a lot of times people get confused what you should use, and and then the sample comes inadequate. For all women that you're doing a smear, you need to, and you do a liquid-based cytology, you need to use both. This is the broom which will sample the ectocervix. This is the brush that will sample the endocervix. So between both is your transformation zone. So if you use both, you will definitely tend to get the cells that you require, and it will not be inconclusive, inadequate. You will definitely get the right cells. So I use both in my practice, especially in patients we are doing liquid-based cytology and then HPV DNA together for testing. But in those women who are postmenopausal, where the cervix has already gone to a type 3 transformation zone, it's very important to use the brush, because the brush will go in and sample the transformation zone, which is much on the inside of the cervical canal. This is where we get a lot of inadequate scores in the postmenopausal women, because we only use the broom. A lot of hospitals or clinics do not have the brush. All right, so try to get it both in the set. And because yes, they say the broom will get the endocervix and this will get the ectocervix, but not in the postmenopausal women. Postmenopausal women, sometimes the transformation zone is much inside and you'll get an inadequate smear. Once you get an inadequate smear, sometimes you miss the HPV cells or DNA cells, and the HPV DNA will be negative. All right. So this is the reason why we use both. All right. As you can see, the transformation zone in postmenopausal is right up there. All right. If you have a type 1 transformation like this, it's fine to use just the broom, because the broom will take the cells inside and take the cells outside, and you get the proper transformation zone. But you have this and you just use the broom, you are definitely going to miss the cells that you need. So I said, conventional pap smear, Ayer spatula slides, let's try to move away from it, because they have a false negative rate of at least 20%. Why? Because it's operator dependent. You need to look at it, you need to see where the transformation zone is, you need to sample the right areas. Another 30 to 40% of all these smears are compromised by blood, mucus, inflammation, which you cannot get rid of because you smeared it on a slide. So it depends on how you smear it, how you fixate it. So rather than go through all this tedious process, calling back the patient, repeating the smear, repeating the slides, let's just move to liquid-based cytology. I mean, that for me, that is a very sensible way to do things. Basically, what it does is using the same brush and broom, putting it in solution, spinning it, and it will give you the cells that you need. All right, because it gives you a mono layer of cells, and the spinning eliminates the blood and the debris. So I think in most states they've already started using liquid-based cytology, especially in the health side, because they realize that it decreases the false positivity and false negativity. It's less tedious. You tend to have better results. You tend to call back patients less. So for me, LBC is the way to go. Most, I think, private GPs and hospitals use it. I just hope one day the whole country will be moved towards LBC. As you can see, the difference between conventional smear and liquid-based cytology. This, you can see everything looks abnormal here. You can definitely make out the abnormal cells. But what is new, and what a lot of patients don't know, and what some of the doctors do, that rather than do a liquid-based cytology and look for abnormal cells, it's better to do a test to look for the culprit that would lead to the abnormal cells. That means rather than wait for the abnormal cells to happen and first pick it up, let us identify the high-risk groups that will develop these abnormal cells, and that's by identifying those patients with persistent high-risk HPV DNA. So that's when HPV DNA testing came in. It's been there for, I think, quite some time. Just that now it's becoming more popular, more aware, and we've started implicating in the primary setting. And why? As I said, 95% of all our cancers are caused by HPV DNA, 16 and 18 carcinogenic, the rest high risk. And we know that 30% of those who are HPV DNA positive with a normal cytology will eventually develop CIN. So we know this high risk group, we know we'll keep an eye. If you don't risk stratify these patients, we are going to lose them, and these are the ones that will develop cancer. And it's been proven. It's been proven in countries like Australia, where they just do primary HPV DNA. They have picked up more CIN2, CIN3 cases rather than doing conventional smears and waiting for it to progress. So for me, the role of HPV DNA, there's 4. As a primary screening tool, which eventually might be in Malaysia. For me, I use it only as a primary screening tool. When patients come requesting for and never done a smear, I do a co-testing. I use it as a triage of borderline cytology results. Like you just get an ascus or you get a low seal and you're not sure what to do with them, you can do a reflex testing. So remember, the patient does not need to do another smear, all right? So it's very different. In Melaka GH, we do smears. If the smear is abnormal or borderline, they will keep the liquid-based cytology and we'll send it for HPV DNA. If they're 16 and 18, we do a colposcopy. If they're either high-risk subtypes, we do a colposcopy for training purposes. But if they're not high-risk subtypes, we just repeat the smear in a year. In my private practice, we tend to do both. And if it's both negative, 5-year follow-up. If they're HPV DNA positive but smear normal, high risk, we 16-18 we colpo. Non-high risk 16-18, smear negative, we repeat in 6 months, right? So it helps us in managing these patients. So we don't need to colpo every patient. It's also a role for following up with positive cytology or HPV test, but without relevant histological lesion. What does that mean? Okay, so the patient has a ascus or low seal, but you do a biopsy, a colposcopy, a biopsy, and it's negative, and you're not sure what to do. Okay, low seal, you do a colposcopy, you do a biopsy, it's normal. So what do we do with this patient? Do we colpo them again? Do we repeat a smear? No, you just basically do a HPV DNA. If you do a HPV DNA, the 16-18 high risk and normal smear, you can go in and do a excision biopsy, get a bigger chunk of tissue. If they're HPV negative, then you can send them back and repeat the smear. Right? I'm going to repeat this again so people are clear. Okay, so I had a recent patient, 42 years old. She came back with low seal. We did a colpo. Outside was CIN1. They did a biopsy, negative. 6 months time, they repeat the smear, high seal. They send it to us for colpo. We did a reflex HPV DNA of 16-18, and then we did a excision biopsy. Why? Because the transformation zone was a type 3. Right? So these are good for those with inadequate colposcopy or unsatisfactory colposcopy. You're not sure whether you want to do an excision biopsy, you're not sure whether you want to repeat the smear, you can always do a HPV DNA testing. It helps you to triage these patients. And finally, test of cure. You treat the patient with coronal LATs. You do one in 6 months, or you do one in 12 months, you do one in 24 months, just to make sure that they are cured. All right. So all patients with a high-grade lesion or precancerous lesions needs follow-up and needs a test of cure. When do you do a test of cure? Certain places do it at 6 months, certain places do it at 12 months. I tend to do a smear at 6 months, I do a co-testing at 12 months, and I do another one at 24 months. You need 2 negative HPV DNA for them to go back to a normal screening process. All right, 2 negative HPV DNA. So this was the guidelines for the primary testing, came out in 2019. HPV has shown to be greater sensitivity and lower specificity than your pap smears. In Malaysia, we do not screen them when they're less than 30s. I told you why, because they are more than likely to have HPV because they're sexually active, multiple partners, not a single partner, not married. Certain countries like America, they do screen from 25 years onwards. Screening interval 5 years, core testing negative, 5 years straight. You know, for me, it depends. Sometimes 3 years, depending on the risk of the patient. We stop screening at the age of 65. All right. When you say stop screening at the age of 65, not meaning pap smears, but a negative HPV DNA. You must have a negative HPV DNA at the age of 65 before you stop screening them. So I have seen patients with just a smear at the age of 65, and I see them back at 68 or 69 with cervical cancer. All right. I have seen cases like that. So if you want to stop screening your patient in your practice, make sure you do a HPV DNA at the age of 65, and then you can tell them you're good. Because you know that a HPV negative result will last for 5 years, and highly unlikely she's going to find another new partner at the age of 70 years old. So, and also as a standalone HPV testing or co-testing. All right, so this is the algorithm. You do a HPV DNA, 16, 18, cop them. If you have the other high-risk subtypes, you do a reflex cytology. If it's abnormal, you cop them. Negative, you just repeat the co-test, the HPV DNA test in 12 months. If you do HPV DNA, they're negative, you send them for 5 years. All right. So this is another algorithm about how you manage high-risk HPV. Positive, you do a reflex cytology. Negative, cop. Negative, 25 to 49. See, they do it based on risk of. When you're more than 40, you can always tell them 50 because the risk of developing a new infection or getting it is much less compared to when you're young. All right. So we target those from 30 to 50, normally less than 30 years old. So what you do with those less than 30 years old, you can always do a liquid-based cytology every 3 years. All right, from the time they're sexually active. 50 to 65, basically you can go 5 yearly screenings are good. So we still promote liquid-based cytology. All right, non-16, non-18 high-risk subtypes, you can always not cope them, just do a reflex cytology negative, always repeat in a year. All right, so this is all in the manual, the guidelines which you can read. So what you do on train, no screening, cytology every 3 years for those 21 to 29, 30 to 65, core testing every 5 years. That's what I love. If you're doing cytology or liquid-based and you can't afford HPV, every 3 years is acceptable. Screening by HPV testing alone is not recommended for most clinical settings. So in our setting, we don't recommend HPV testing alone in this age group. Why? Because if you do HPV in this age group and they're positive and you don't do anything about it, it's a bit difficult to triage them, right? 65 and above, no screening, all right, following adequate negative. So you need to do a HPV DNA when it's 65. After that, they're good, all right? Those with a history of hysterectomy for precancerous lesions need screening, as I said, 6 months, 12 months, and 24 months post-hysterectomy. All right, to make sure they clear of the virus. Okay, so you see a lady with 60 years old with CIN3, you do a hysterectomy for her. You must make sure you follow up her at least for 2 readings that she's cleared off the virus. All right, HPV vaccinated follows the same as the unvaccinated population. All right. This is what, the study that what we know is that about to get away from using the cuscal speculum. So as I said, most women are afraid for pap smear is because of the duck bill. They shun from it, they run away basically, It's not whether it's a male or whether it's a female, they're shy, no, it's the duck bill, all right? You can ask any women, they said it's just painful, all right? So knowing that, and knowing that now we've got liquid-based cytology, which we only need the cervical vaginal fluids, we have started self-testing. So I'm not sure if you notice, if you go outside, you can get self-testing HPV self-kits. You can do it on your own at home and then send off the results, and you get back a result, right? This is fantastic, and it's so easy to do. We did a pilot project in Sabah before I left. 100 nurses, they came to my clinic. We showed them a video, we showed them a chart. They went to the toilet, they did it. Less than 1 minute, they're out, and we've got 100% results without any unsatisfactory results. It is easy, all right? And I think this is the way we should go, you know, especially in rural areas where it's hard for them to come out to the clinic. We should just send the test kits out to them. All the women come out, get the screen. Those who are high-risk HPV, we take them, we go to them, we help them. Those who are non-high-risk HPV, we'll tell them you're good, you know? So self-sampling, I feel, is a way forward in Malaysia. Why? Because we've got a lot of rural areas, especially in East Malaysia, where it's very hard for them to access to the facilities that West Malaysia has, like HPV, DNA testing, liquid-based cytology. So a study done showed that recombinant cell study for HPV may increase screening coverage, and it's shown, you know, and it's very easy. We've got a Delphi kit, we've got, you know, because all you need, you don't need to see your cervix. All you need is the cervical vaginal fluid, all right? You can take it in whatever position, all right? The normal one is recommended with one leg on the chair, you slide it in, take the fluid, put it in, and it's most comfortable. But whatever way you want to do it, you can always do it. All you need is the cervical vaginal fluid and then put it in the liquid base. It is easy, it takes less than 1 minute. So self-screening, very new in Malaysia. We're talking about it. I'm excited about this because I'm thinking of bringing it into my practice. Why? Because it will save me from bending over every time I need to do a pap smear and looking through between women's legs. So now they'll feel more comfortable doing it on their own. They feel that, yeah, they've got some self-empowerment that they can screen their own selves for cervical cancer, and soon it'll be available in, I think, most commercially too. So I'm hoping one of the major hospitals or one of the labs will start commercializing this, and more women will come forward to get screened, and that will improve our coverage and try to reduce the risk of precancerous and eventually limiting cervical cancer. So we have done well in Malaysia. We've moved on from conventional pap smears to liquid-based to HPV DNA. But for me, this is the next step forward to improve our screening program. But we need to find a good way to implement it. It's easy, convenient, painless, cheap, and we've done it. I've actually done it. I've seen it, and you'll never get an inadequate smear. You'll always get the right, because all you're doing is testing the fluid. All right. You can start it from your practice, show them a video, put up a chart, give them the kit, they send it, pay it, that's it, you get back the results. You know, it's easy for them, less work for you. Financially, it's not the same, you know. So self-sampling is something that we will need to look at, and it's exciting, and I'm hoping that it will be a huge hit in Malaysia. So many devices. Delphi screener, I was part of, you know, when it first came out in Australia. We went for the Aboriginals and we gave them, and you know, we never got back the screener test, but we got back the fluid, you know. So there are a lot of equipment out there, especially vaginal friendly equipment, you know, some shaped like a dildo, some shaped like, you know, so it's very easy and convenient for women to do it. But we just need to promote it. So hopefully soon it will catch on in a big way. I think women will actually love it compared to the duck bill, and I really hope that it really picks on in Malaysia. So finally, just to brief that what we do a co-testing, if you are planning to do in your practice, negative 5 years, high risk HPV depends 16-18 colpo, non-high risk repeat the smear in 1 year, and normal smears if you just do with HPV positive, colpo them. All right. So this is what we want to achieve in the next 8 years, which I think we can, as long as we improve our screening. We need to hit the targets, all right? We need to meet the 90, 70, 90 targets. 90% of girls fully vaccinated with HPV vaccine by 15 years of age, check. 70% of women screened using a high performance test, not happening now, and we're only getting about 50. 90% of these women who are identified to have precancer lesions are treated, which I think we are doing, right? Which we are doing, okay? It's this area that we need to work on, all right? And it's this area where liquid-based cytology, HPV DNA testing, and especially self-sampling would definitely increase the numbers. All right, and I'm talking about rural areas like East Malaysia and East Coast, East Malaysia, like Sabah and Sarawak. Again, reiterate, 90-70-90. Anything you don't remember, just remember this. We need to get 90 girls fully vaccinated. We have done that. 90% of women with positive cervical screening disease treatment. I think we've got almost there. We're not almost, because a lot of times the results are traced late, get lost. So but I think we're almost there. 70% of women, that's where we need to catch up. We're only probably now only about 40% to 45%. So that's the area we need to target. Okay, and I said the age group that we need to target are those from 35 to 55. I mean, those are the ones, you know, which are high risk because they will have persistent HPV, not the one less than 30. So when I see a young girl less than 30 with HPV, then I tell her not to worry, go off, enjoy life, come back and see me when you're 5 years time. We'll repeat the screen. If you are HPV DNA positive, then we got to do something. So we want to target those one 35 to the age of 55, where the infection has already been there, had some damage if they did so that we can treat them. I love 90-70-90 in multiple forms. This is what we want to achieve, and I do believe Malaysia will be able to achieve. I come to the end. I would like to thank, I said, all my knowledge, all my experience are due to my patients. So I would like to thank them for all the experience they've given me. Every day I learn something new from them. So my take-home message is early detection saves lives. It's not the surgeon who does the radical surgery. It's not the chemotherapy. It's not the radiotherapy. It's the early detection. It's the primary. We're going to win cervical cancer is because of the primary care. All right. We're not going to win cervical cancer by getting more and more gynae-oncologists. We're doing more fantastic surgery, laparoscopy, lab robotic. Nah, we do not want that. We want to catch them early, treat them early, prevent them from getting that. All right. Gynae-oncologists should be the last frontier. Yours should be the first. Yours should, you know, when it's bad, then you just send it to us to try to salvage something. But the primary healthcare is that's where we got to detect them early, treat them early, get them early, so that they don't come and see us. All right, and that's when we're going to win against cervical cancer. All right. So thank you very much for listening on a Saturday afternoon. I think you've just made it on time, just before 10. I will pass back the floor, the screen sharing to Dr. Murali.
Very insightful.
Thank you.
In the interest of time, I'm just going to run with the questions. We've got a couple. I think the first one is one we didn't cover earlier on if a patient missed the 3rd dose of the nanovalent vaccine, then comes back 2 years later and requests to be revaccinated. What's your advice? How do we carry on with this patient?
Yeah, so you need to complete. Studies have shown if you wait more than 6 to 12 months, if you have not completed, you need to repeat the cycle. So 1 year is more than 12 months. You have to repeat the 3 doses. Why? Because you will not achieve the therapeutic benefit. That's it. It's all about antibody levels. Okay. You get them accordingly 0.16, you get the 95%. 0.1, and you get it 8 months. Yeah, you still can get the 90%. 0.1, 12 months, probably 90%, but it's 0.1 and then you miss the last one and you repeat in another year, just 1 dose, you're not going to achieve that. So you don't get the antibody levels, you're still at risk of getting the virus, you're still at risk of getting pre-cancer. So 6 to 12 months, anything more than that, you need to repeat the cycle.
Well, Doc, and just an additional question, because I think just now you're talking about people on the first, who maybe taken 1st and 2nd dose of your quadrivalent, and now could they switch to nanovalent?
No, so you take 2 quadrivalent, you cannot get 1 nanovalent now.
Okay.
It doesn't work that way, right?
1 quadrivalent boleh dapat 2 nanovalent kan?
No, it's not as simple as that. Yeah, you still need to do the full course of, because it works differently. Yeah, okay, and it works in different subtypes. So you need to finish that course. So I've had patients with complete that. I said, no, if you want to switch, you switch now, but you need to take all 3. But you don't need to wait. You don't need to wait like, I need to wait 6 months so that, if I take someone, will I get extra HPV? Like if I do 6 doses of it? No, it doesn't work that way.
Okay.
So, yeah.
Okay, got it, Doc. And so then if someone has started the quadrivalent, let's say you've taken 1 dose, then if you're going to restart nanovalent,
how long do you wait?
No wait, but you need to do the other 3
Start back with a
doses.
0.1. Yeah, go back to origin. You don't need to wait.
Okay.
it's fine. All
Okay.
right. Yeah.
Okay, lovely. Doc, another question, and I'm hoping that we've caught everyone at lunch already. Has the vaccination success resulted in lower incidence? Okay, or has there been a downtrend of the incidence of the disease in Malaysia?
Yes. Definitely yes. Definitely yes. The vaccination started in 2010. As I said, we will only see the results after 10 years.
Right.
And in 2020, the recent results, we are seeing a downtrend. The incidence is reducing. But you see, if I see it because in my practice, that's what I see on the daily basis. You all might not see it. And the reason why is that the numbers also are increasing because of the people are living longer.
The extension, yeah.
So it was, people are living longer, they're bound to get it because they're not screened at that time when they were young, they didn't get the vaccine. So, I still see patients at 80 years old getting cervical cancer, Yeah. So people are living longer, the high incidence. But if you look at the age-related standardized incidence, you are seeing a downtrend in it. Okay. I see less and less bulky, I see more and more pre-invasive now.
Right.
Probably do I still say they only do 4-5 per month. I was doing, when I was training last time, I was doing 2 or 3 per week.
Yeah.
I remember doing 3 word times in a day.
Right. Wow.
Yeah. 3 word times. Now it's rarely now to get word times, so they'd be all quite excited. So we are definitely seeing a good trend. It's only 10 years. So I think in another 10 years, we will definitely see.
They'll be writing to India to go and get attachment.
True. But looking at India,
they may beat us at this.
Yeah, exactly. But don't worry. Just quick one, if I can answer. Thoughts about self-sampling.
Oh, I'm a big advocate of it.
Okay,
I think it's the best thing since toasted bread.
Okay, true, toasted bread, right? No, but I think it's fantastic, right? I think it's a brilliant idea. I know I told you, my nurses, 100 nurses, and they felt fantastic. We screened it. It's so easy. But what do you think in the Malaysian perspective? I mean, Malaysians, how do you think they would they be receptive to it?
Well, I think a lot of people are receptive, and we're getting more and more people rolling out self-sampling. I think LPPKN also has its own self-sampling kit already.
Right.
And so does other organizations. MOH has a separate self-sampling kit as well.
Okay, so let's talk about MOH now. So when would it be available to all health clinics, or would it be available to hospital? Any news about it, just to keep us excited?
Okay, so currently they rolled it out in 2019, 2020, went to about, I think, a pilot of about, I think, 20 clinics nationwide, but it's to health clinics, not in hospitals.
Okay, all right.
Which is good. And,
which is good, which is target, which is exactly what we need, yeah?
Mm-hmm. Yeah, and we're hoping that there will be expansion of that pilot.
Right. And sorry, I'm just asking, reversing the roles now. The cost of it, and would it be available in private hospitals? I think in private hospitals it would be patients come for their appointment or whatever, you just say, why don't you do this? They just go to the toilet, they're done. I think it would be good,
Absolutely. Absolutely, Doc.
Any private labs doing it?
Both Pantai and LabLink are kind of rolling out their own self-testing as well. So it'll be available to most GPs. We're working together with both of them to actually roll out self-sampling across to every single GP in Malaysia. I think that's what we want to do.
I think that's very good. I think that's the way to go. I think, we're struggling with the screening, just to get the numbers. And I think, this, I really, really hope it, picks up, and it'll be great. It's good. It's exciting. Yeah.
Lovely. Hopefully 2023 is a lucky year that we get this off the road. It's been quite a long time in coming. I think we've all been dead because of COVID, but things are restarting.
Time to recharging. Yep, true.
Doc, a question on, I think, from our colleague on what is reflex cytology?
Okay, reflex cytology is when you just do a HPV DNA test, which I tend to do if in private practice, which we don't in government. Most of the time we do a liquid-based cytology. But in private practice, I just do a HPV DNA test, and the lab will keep the sample, the same sample, the liquid base. If the HPV is high risk, then you have the option of asking for a reflex cytology, where they will read the cells and tell you whether it's a normal or abnormal. That is reflex cytology. So most, I believe all labs will have a standard period of time where they will keep till you review the results. And if you feel that you need a reflex cytology, then you do it. So in my practice, I do a HPV DNA. If it's 16 and 18, I straight away colpo them. So I don't do a reflex cytology, because for me there's no benefit. But if you cannot colpo them, then you should do a reflex cytology, and with that results, then you send them or refer them to someone who, if they are other high risk subtypes, or they are like not 16 18, and then that's when I do a reflex cytology, because colpo is invasive, right? And so, you still have to use the duck bill, and most women are like, no. So I try not to do it. So if they are non-16 18 other high risk subtypes, I just do a reflex cytology. If it's normal, I just tell them, don't worry about it. We'll see you back in a year or 6 months to a year. We'll retest you for your virus, because we know that the virus is there. We hope the virus will clear off. As long as the virus clears off, it's not going to change your cells. Your cells are fine. So that's what it means by reflex cytology.
Right. Got it. Thanks so much, Doc. Okay. And I think we're going to take this as a last question, I think, to wrap up the session. There's a colleague who asks, do you advocate replacing conventional pap smear with liquids-based cytology? I think, yeah, that was the thing.
Definitely. I take the stick, use it as an ice cream stick, throw it out. I think we've way past that. Yeah. I can remember the days when I was an MO or houseman, I was going through pap smear results, and oh my God, everyone's inadequate, unsatisfactory, no transformation zone, some either obscured, blood, thing, cotton. Oh my goodness me. Let's do away with the stick. Let's do away with conventional. Let's all go towards liquid base. Some people say it's more expensive, but the price is coming down. As long as more and more people use liquid base, the price will definitely come down, and I can see the price coming down. And it's much better. It gives you better results, more efficient, less time consuming, and you get more information.
Okay, absolutely, Doc. And I'm just going to throw in the Chinese New Year special for that. So for our colleagues who want to do liquid-based cytology and are worried about cost, please get in touch with us, in the sense that we do a lot. We do a couple of thousand a year. So generally, we have a much how to say, you can be very happy for you to use our accounts, in terms of if you're doing mass testing within the poor or something, so that we can bring down these costs. The cost for liquid-based cytology has come down significantly over in the 4 or 5 years that even I've worked in the Cancer Society. So we've brought it down quite a bit, thanks to our labs. Pantai, Labeling, and others who have really cooperated in bringing down the cost for LBC. But we can give you even lower assistance, and that's really not a commercial basis. Just because we're doing a lot more with the labs, we're happy to share that on to any of our GP colleagues who want to avail themselves of it.
Fantastic.
Okay, so with that, I think, Doc, we've kind of exhausted everyone and yourself as well. Thank you so much for spending a Saturday morning with us. And I think
thank you, Dr. Murray. Thank you so much.
I'm just going to ask you to see whether you've got any kind of take-home messages that you want to leave us with.
I said my take-home message is that even though I'm a gynaecologist, my passion is basically screening and prevention, because for me, that's where we should go. I mean, all types of cancers. Cervical cancer, we've got amazing tools. Endometrial, we detect them early, so not so bad. Ovarian, I'm still trying to work out. I think screening and prevention is the only way we can tend to win among most cancers. So I advocate for you to do your health checkups, go for your screening tests, so that we detect them early, we definitely can save. You detect them late, we struggle with that. So wherever you are, doctors, you're working out, for me, opportunistic is great. Catch them, offer them screening, detect them early. The morbidity of treatment is less. They have a better quality of life. So early detection saves lives. Is the way to go. It's not radical surgery. It's not radical chemotherapy. It's not radical radiotherapy. It's not high fancy drugs. No, what we're doing is just salvaging whatever that we cannot salvage. If you want to save a life, get screened, get treated, and prevent it. So that's my take-home message. Another thing, Dr. Murali, thank you so much for having me. My heads off to NCSM for doing the amazing work that you guys do. I'm glad we're working back again together in Malacca. Keep up the good work. Thank you for the support. And hopefully we will save more lives and a better 2023.
Yeah. So thank you so much. ladies and gentlemen, for joining us. This was the SK Dharmalingam series. We spoke about cervical cancer today with our guest, consultant, gynecological oncologist, Dr. Arivendran Dhorai from Pantai Hospital, Keroh. So wishing you all a happy Chinese New Year. Hopefully it's a productive year of the tiger next year. And we're looking forward to World Cancer Day as well, which is next Friday, on the 4th of February. And we have like a series of activities that, including some sessions on Docity. So hope to see you soon here as well. So have a nice weekend. Thank you very much and goodbye.
Thanks, everybody. Have a good one. Bye.